My name is Ourania Kolokotroni. I'm the chair of the Department of Primary Care and Population Health at the University of Nicosia Medical School and the director of the MSc in Family Medicine program. It's a pleasure to have you all tonight on this lecture that will be delivered by Professor Kevork Hopayian on the benefits of family medicine for a nation's health and efficiency of health services. Professor Hopayian is clinical professor of general practice at the University of Nicosia Medical School, and he's a GP that has been working for the UK NHS system since 1985. He's a fellow of the Royal College of General Practitioners in the UK and has been acting for the past 10 years and as a clinical skills examiner for the college. He's been working with us at the University of Nicosia Medical School since 2015, and he's been instrumental in leading the curriculum development of the MSc in Family Medicine program. He has a special interest in evidence-based medicine. He has also authored a book on this topic, and he has also other interests in regards to medical education and health service organization. So we're very happy to have him with us tonight to deliver, as we said, the first lecture of the series on family medicine. This session will be recorded, and you can get the recording of this session to watch it later on, or also send it to friends that might be interested on this topic. And just to say that this presentation will last about 35-40 minutes. There will be different kind of times when Professor Hopayian will be answering questions that you might have. So please use the chat box to write all your questions, and I will be summarizing those questions to him at the different time intervals when he will stop his talk and be inviting questions. So welcome again to this evening's session, and I'll give the floor to Professor Hopayian to deliver his talk on the benefits of family medicine for a nation's health and efficiency of health services. Thank you.
Okay, well, thank you very much for those kind words, Ourania. I didn't recognize myself there. That was over too kind. So, right, let me first of all thank everybody for joining us on an international collaboration. I'm here in grey, wet, cold England on the coast on the East Coast, and our hosts are in nice, warm, sunny Cyprus. We've got guests joining us from around the world. This is a particularly good day, auspicious day to hold this, because it is, of course, International Women's Day. And as we know, all around the world, one way to help women in the poorer parts of the world is to give them education, contraception, good antenatal care, good general medical care, and we improve their life chances, their quality of life. We lift them out of poverty and help the families out of poverty as well. So family medicine in the primary care sector does have a part to play in providing good medical care. And what I hope to do today is to convince you of that fact. I'm going to start our presentation. And okay, right. Okay, I can see I have to hit the track back. So the very, I've called this the benefits of family medicine for a nation's health and efficiency. That's because I've been a family doctor or general practitioner, and I'm teaching on the family medicine MSc at the University of Nicosia. But there's more to it than just family doctors. In many parts of the world, family doctors belong to a team, usually at least a nurse, but increasingly a wider number of workers, for example, maybe allied with antenatal health, social services, and the like. So every now and again, you may find me switching from talking about family medicine to general practice to primary care. So our aims are to look at the effects of primary care on the health of a nation, what it does to the healthcare costs, how we can get access to healthcare for all, and also how satisfied are the patients receiving the care. how are we going to do this? Well, I'm going to draw on the evidence that has been compiled from around the world on health service and health service organization, particularly showing the effects of primary care. At the end of each section, we'll stop, there'll be some question time, and we'll take the questions up to that section if you like, but of course there'll also be the opportunity to ask questions at the end. If you want to type in your questions in the chat box, or if during the discussion you want to say anything, and you can either chat or raise a hand, and if I'm on my toes, I'll see your hand and respond then. So it being International Women's Day, I should mention Professor Barbara Starfield, who back in the 1990s did a lot of the groundbreaking work looking at the effects of primary care, and some of the methods that she developed continue to be used by the researchers that I'm going to quote today. Okay, so before we go any further, I'd just like to recap the basics of health service organization, just that we know we're all talking about the same subject. Okay, so health service has got to have kind of three parts to it. One part for raising the funds to pay for it. And there are several ways of doing that. Once upon a time, it was mostly people dipping into their pockets, personal payments, but we now have private insurance, and in many parts of the world, there's taxation or social insurance is used to cover. Then you've got to pay the providers. Now, I'm not going to go into much detail at all, because that we could spend a few hours on. Governments around the world have, and indeed private insurers around the world, have played with lots of different methods of paying providers to incentivize them to get the best out of them. And then finally, there are those who provide the care, and that can be provided in different ways, either by private institutions working for a profit, charitable institutions working similarly but without necessarily making a profit, and then in many places, the state runs clinics and hospitals, either nationally or through local authorities. Okay, so now I'm going to talk about two models of providing primary care. This is the model that is probably pretty widespread around the world, an open market where either people are paying for themselves or it's being paid for by insurance. They have the choice of who they go to see. They can go to see any primary care practitioner of their choosing, or they can go directly to second care. That's at one end of the spectrum. At the other end of the spectrum, we have the registered list or panel option. This is where a group of people register with a single provider of primary care, and their first contact with the health service is with that provider, who goes on to provide continuing care during the year or for longer. And in order to get to see the secondary care specialist, you will need a referral from them. Of course, the primary care practitioner continues to coordinate services, including with other agencies. For example, as I've said before, it might be with social services or the like. Okay, now when we look at health services to compare them, there are four things that health researchers and health economists look at. One is effectiveness. That's to say, how much years of life are we adding? How much quality of life are we adding? How much disability are we reducing? When it comes to efficiency, we're asking, for a given amount of money that we spend, do we get the maximum effectiveness that we want? Healthcare costs have been rising tremendously over the past decades, and governments around the world are trying their best to keep a lid on it, what's referred to as cost containment. Then we're all painfully aware that there are many people around the world who don't actually have access to healthcare, and equity is another thing we need to measure. And finally, are patients satisfied? Do they get the care that they want, the experience? So there you have the 4 E's. I'll be asking questions, I'll be posing research questions about each of these topics, and then providing you with some of the evidence for them. Okay, so here's the first question. Do countries with a strong primary care sector have better health outcomes? Okay, now, let me explain how these people have gone about working this out. The certain characteristics of the health service are looked at. For example, the structure, the accessibility, the services that are offered. And these, each of these characteristics is given a score. In this particular case, they've chosen a score of 0 to 2. You can then add up all the scores for each of those items, and you end up with an overall score for how strong your primary care sector is. You can then look at that against different types of health outcome. Now, in this case, they've looked at the health outcomes in terms of premature years of life lost. In other words, how many years were lost because people died before the age of whatever you agree should be a reasonable age to expect. Okay, so if we have a look, so here we have the number of years of life lost, and along here we have the results for the years that this study was run. They divided the countries that were in this study into two groups: those with a low primary care strength sector and those with a high primary care sector. Okay, so those are two. Which countries did you look at? Well, of course, you can't look at the whole world because health is determined by lots of other things, such as the wealth of the nation, climate, obesity, etc. So you want to compare countries that are fairly similar. And these were countries that were in the high income groups in the OECD database. So the interesting thing about this study is that it was repeated over several years. Okay, so you can see that when they started the study in the 70s, high primary care countries had fewer years of life loss. In other words, they were doing better. Now, those of you who've ever seen league tables where people try to compare one university to another or one hospital to another are aware that there's always a little bit of noise in such comparisons. You know, there may be some kind of random variation that explains it. But when you see the same thing happen year after year after year, you say there is a definite trend there. High primary care countries do increase life expectancy. They reduce the premature years of life lost due to avoidable diseases. Okay, this is from Starfield herself, an earlier study, when she looked at what types of health outcomes were particularly good. Her team found that countries with a strong primary care sector had fewer low birth weight infants, which we know is an indicator for morbidity and for mortality, lower infant mortality. Interestingly, again, mental health was better, fewer years of life lost due to suicide. And they all had high life expectancy. Well, at all ages, you know, whether you're a child, adult, except when you get to the age of 80, which is hardly surprising because you're reaching your limit at that point. Okay, so how does primary care do it? So these were global figures we were looking at. But you want to understand, is there a mechanism that could explain why this is actually happening? Okay, so what you then need to do is to look deeper into some individual studies and see which aspects of primary care seem to make a difference. And here are some of them. In an open market where you can see one family doctor 1 week and another one a few weeks later, you don't get continuity. If you can see a specialist just when you have a problem, you may well get care for that problem in reaction to the problem. But when you're registered with a GP, you get proactive care that goes on for a longer period of time. Also gatekeeping, practitioners being able to refer appropriately to the specialist that's needed. Comprehensive care and coordination. We'll talk about those as we go along. Okay, now you could say to me, Kev, okay, this is all very well, you're comparing one country with another. That's not really fair. You know, what if some countries have got more obesity or more smoking, etc.? Well, I did say at the beginning that countries were being compared with like countries. But one way around that is to look at differences within countries. So here was another study done in Sweden, where over a decade ago, the local authorities were given the job of placing patients in their areas onto GP or family doctor lists. And so everyone was passively put on the list. Now, those that decided they definitely want to be registered with one place had to actively register themselves. So you had two groups of people. So this is a nice controlled experiment, natural experiment, two groups of people, those who are actively on the list and those who are not actually on the list. Yeah, they're there only in name only. And then they looked at some various health outcomes. And in this case, it was admissions to hospital. Look a little carefully, because let's see now. You will notice that those who are on the active list have fewer hospitalizations than those who are not. You could say, Kev, yeah, but maybe the people who got onto the active list are those who are more ill, or they just go to see the doctor more often. Therefore, they get their problems sorted out. Not necessarily true, because you have to compare like with like. So they matched the groups, adjusted the figures for the groups for things like comorbidities. And furthermore, notice it doesn't matter how often you see your doctor, that effect is still there. Being actively on the register seems to make a difference. Okay, so onwards and upwards, let's carry on. Here's another study looking. This time it was a systematic review. That is to say, rather than this individual studies which I've quoted, this study reviewed all the relevant primary research on the subject and found, again, that where there was continuity of care, there were reduced attendance by patients to the emergency department and fewer admissions as emergencies. So primary care is doing something to keep people out of hospital and to stop them suffering from urgent problems. Okay, now, if I'm going too fast, do put your hands up. I have to be honest and say I get very excited by this subject. So do put your hands up and stop me, or somebody shout, and I'll slow down. Now, I'll explain this next one. I've created this graph to make it a little easier to understand. It's a fairly new study. And now we're not looking at necessarily emergencies. We're looking at long-term conditions, things like diabetes, asthma, high blood pressure. And some years ago, a survey was conducted in the European Union, asking patients with these long-term conditions what their experiences were. So they were asked three sets of questions. How good is your health? How limited are you by your condition? And do you have problems that have not been treated, that you've not had access to get treatment for? And if you remember earlier, I talked about how you could give a score to the strength of primary care using various descriptive techniques. Okay, so these people did the same. They used a score, slightly different to the one that I mentioned before, but they were able to give a number, kind of a rating, if you like, for each country's primary care sector. And then the analysis was to compare the strength of primary care against the reported, let's say, the perceptions of health from the people in the survey. Okay, so now, if we have a look here, being in good and very good health is a good thing. So if you have a positive correlation, that's good. Being severely limited and having untreated conditions are bad things. So a negative correlation is a good thing. Okay, so we're quite clear on that. So here I've plotted the correlation coefficient against the aspects of primary care that these people measured. Okay. So how good is the structure in primary care? How accessible is primary care to patients? How much continuity does it give? How much coordination? And how comprehensive is it? Okay, so let's look at the results. So in good health, we've got positive correlation, positive correlation, positive correlation, which is what we want. For severe limitation and untreated conditions, negative, negative, negative. We won't mention these because the differences there are so small that they're not statistically significant, they could have arisen by chance. So you see where we're going. Primary care prolongs life, reduces hospital admissions, in other words, reduces emergencies, and is satisfactory for long-term conditions as well. Okay, I'm going to stop at this point and take any questions if there are any. As I say, do raise your hand or type into the chat box. Let me see if I can see them.
We haven't had any in the chat box yet, but if people want to type something now, any questions up to now? We've got the first one.
Yeah. What impact do you feel telemedicine? Okay, right. That's a great question. I hadn't prepared for that. Perhaps you weren't here. I don't know if you heard the intro. My main aim today was to marshal all the evidence that we have, both pro and anti, of course, being balanced, to show the effects of primary care. I haven't really kept up with the work on telemedicine. Be fascinated to know if you can people unmute themselves and speak. If you could tell me what your experience has been so far. Are we allowed?
Hi there.
Yeah.
Hi, Grace. Yes. My experience is from here in Finland and in the Nordics. There is a large movement towards telemedicine, especially there's been an added sprint during the COVID times. Engagement initially was really high. There was a large kind of acceptance and a low threshold to engagement from the patients. However, the kind of sustained outcome or satisfaction wasn't felt as strongly, and that what I've heard that the kind of patient-doctor relationship suffered a little as it felt kind of cold, and people felt a lack in that kind of the warmth and the relationship during a consultation.
Okay, well, thank you very much. I look forward to seeing what comes out of the evaluations that will inevitably follow. Okay, all I can do is offer my own personal experience, where I found it works extremely well, and I don't know if that's because if it comes down to how you do the consultations, very few people have refused to have them, and we still, of course, follow them up with personal face-to-face meetings. So I've had a positive experience so far, though I do know that when you do offer somebody an appointment, face-to-face, as I did only last week, the gratitude you get just for doing so clearly means that some of them were hoping for it all along and hadn't expected it. So yes, we're certainly going to have to change the way we work here in those countries where telemedicine is a possibility. But one of the things, the big challenges for the rest of the world is just to get basic primary care going. Okay, so do you have a study effect about waiting list on primary care? We'll come on to that. Actually, that's a great question. Thank you, Dr. Mohammed. We'll come on to that when we do the experience bit.
Kev, can I just say something about the telemedicine aspect? I mean, okay, I understand and I agree with Jack Parker on the effect that it might have had on the doctor-patient relationship. On the other hand, there have been, there are also positives in regards to telemedicine, because you can reach people in areas which are more remote, as long as, of course, they have internet access. And sometimes you can reach people that of lower socioeconomic status because of the fact that they might not be able to travel to their doctors, or they don't have childcare to look after their doctors. So in Cyprus, for example, I am a pediatrician, and what I found was that parents found that through telemedicine, their access to the doctor was easier because they didn't have to have childcare for one child so that they can take their other child to the doctor and so forth. So there are positives, and obviously there will be negatives to using telemedicine in primary care.
Great. Okay, thanks for that. So we'll move on, and I'm going to ask the second question now. Do countries with a strong primary care sector use resources more efficiently? Okay. All right. So let's. The next few slides are taken from the Office of economic cooperation and development. Here we're looking at how much a country spends of its wealth, its gross domestic product. How much of the wealth goes on to, I'll start again. I'm very sorry about this, okay. So, sorry, we're comparing now how rich countries are by looking at the wealth they have measured as gross domestic product per head of population. Okay, so if your GDP per capita goes up, it means you're wealthier. And that plotted against life expectancy. Now, you would, of course, expect that the wealthier nations, they're going to have fewer communicable diseases, less poverty. And so, quite understandably, as countries become wealthier, the life expectancy goes up, but then it starts to level off. And if anything, it seems to drop once you start getting to the wealthiest nation in the world, the United States. Now, as we know, the Obamacare, as it was called, or the Affordable Care Act, tried to bring that kind of 1 in 8 people in the USA that had no insurance into some kind of insurance scheme. That could explain parts of it, but also they do have a weak primary care sector. Now, you could say, well, how do you work out how much of your spending should go on primary care? Surely it depends on how much you've got to play with. Not really. It's a political choice. In other words, it's a choice that a country must make when designing a health service. How much of our health service is going to go into primary care, and how much of it is going to go into secondary care or administration, bureaucracy? Okay. Now, here we're comparing how much each country spends on health overall, and how much it spends on the primary care sector. And these are some of the countries that you saw in the previous graph that were doing very well in terms of life expectancy. And you can see that they're spending a considerable amount of their that are investing in primary care to give it a strong primary care sector, are also in that section there. Okay, so what about cost containment? Remember, we mentioned that at the beginning. This again is taken from the OECD, looking at how much countries spend on health as a percentage of their wealth or GDP. And over the years, something that I mentioned before, a fact that we're all aware of, healthcare spending is going up and up and up. But notice the country that's going up fastest and pulling away from the most is the USA. And a lot of that, it comes down to the administrative structure. They have so many different ways of raising money, employing people, and paying them to do so, going back to that very first slide of ours, that nearly a fifth of what they spend on health actually goes on bureaucracy and administration. Okay, so now, there's a lesson there, but not related to what I'm talking about. If you have a streamlined public care sector and a streamlined health service, you also get efficiency in that respect. Okay, why does this happen? Well, again, if you look within the country, you can when patients are seeing more than one secondary care doctor or more than one primary care doctor, they get repetition of tests. They get far more tests done than they would if they were seeing somebody providing continuing care. And so the whole thing spirals upwards. Okay, I just want to stop there again and take any questions if there are any.
Kev, have you got any data on China? How does China, maybe I didn't look in the graph there, because China is a rich nation.
Yeah, good question, Sonny, good question. I haven't got that type of data for it. I shall certainly be searching still. They have reorganized their health service recently, and I was going to mention how they've done that. It is a high income country, but it does have pockets of extreme poverty, which and something I'll mention a little later on in terms of what they're doing to correct that. But we don't have that. I have not seen that type of study. For one thing, in the absence of a primary care sector, it's difficult to actually measure the primary care sector. There have been some studies on patient experience, which we'll talk about in a little while. Okay, so someone's asked, does the way you pay your doctor affect the quality of primary care? Okay, there's a long and a short answer. The short answer is yes. The long answer is it's very complicated and the subject of another seminar. So if the University of Nicosia invites me back, I'll go into that. But let me just repeat what I said earlier. Many different methods have been tried. Per capita, that's you say you pay for each person on your list. You pay for doing things like every time an injection is given, fee for service, or you pay for hitting targets. Do you achieve 70% COVID vaccination, for example? And each one of them has their pluses and minuses. Getting the right balance is difficult. The more you tend to give fee for item of service, and if that makes a huge difference to people's pockets, earnings, that does distort what they do. Okay. We have a mention from Saeed Soliman, experience from. Yep, I'm listening, Saeed. Hello, Dr. Saeed.
Sorry, Dr. Kev, I was about to write that experience from Middle Eastern countries like Egypt, that there is some distribution of the pay, not only from the pocket, there's large amount from the pocket of the patient. And recently the government started, can I say, getting rid of its responsibility for the essentials of primary care. So we have a new universal health insurance, but sadly it doesn't include very basic services like vaccination or family planning. This is a very national concern that our new national insurance system doesn't include these services. Just this was my contribution.
All right, no, thank you. That's very worrying. Okay, so someone's okay. Dr. Mohammed, thanks for the question. I won't answer whether I'm for or against capitation, largely because I want to approach the subject today in a scholarly way and looking at the evidence, and then deciding afterwards what we think is the right way to go about things. Thank you for your challenging questions, but that's what I'm going to duck. So let's get back now just to here and answer the next question, because I think what Dr. Said from Egypt has just said is worrying, because one of the things we want to see is we want people to get access to the care they need. So the next question I ask is, do countries with a primary care sector serve the people who most need it, the poorest people, those with the worst health, better than other systems? Okay, now this is, don't get too worried about the detail in here. I just thought it would be easier to show you a picture than to show you a bunch of numbers. But what's done here, this again was a survey that was conducted within Europe and neighboring countries. Patients were asked if their healthcare needs were met. And in each country, there was a comparison between people who were in the lowest fifth earners, these hollow bars, compared with the highest fifth income, the solid bars. And you can see you can see at a glance the degree of inequality in healthcare needs in these countries. There's a big difference between the poorest and the richest. And it gets less as you come down here. Now, these, of course, are richer countries. They're not necessarily more egalitarian. Some of them are, but not necessarily so. There's something else that's quite interesting about these countries, which is I've marked with these red arrows. These red arrows represent countries that have got skilled primary care practitioners, skilled family doctors. That's to say that the level of training required to enter family medicine as a specialist is high in these countries. And notice the countries that have kind of reduced inequity, or put another way, improved equity, have got strong, a skilled workforce. So in this particular study, yes, how the background economy does make a difference, but then so does your ability to get to, if it's free at the point of care or not too expensive at the point of care, people have access. And if you train your practitioners to a high level, they will provide a high service, including some of the things I mentioned earlier, proactive care, and very much in connection with Dr. what Said said. Access to all types of care, contraception, vaccinations. These are the things that are going to reduce health inequalities. Okay, I'm going to mention something called the inverse care law. This is a phrase that was coined by Dr. Julian Tudor Hart, a well-known campaigning general practitioner in Wales, who looked at the distribution and quality of care in the United Kingdom and reported that those areas that had the worst the worst health problems, namely the poorest parts of the country, were the ones that got the least good care. And this is less true, I think, now than it was then. But even now, we still have a disparity. But around the world, of course, it's much worse, and especially in those places where people don't have access to care in the first place, which is why, one of the sustainable goals for the future is to get universal coverage for all people everywhere. Okay, I'm just going to stop again there to see if anyone's got any comments before we come to our final round. You'll be pleased to know we're nearly finished. Okay, no, we've stunned you into silence there. Okay, you're saving it up for the end, I hope. Finally, experience. So, do countries with a strong primary care sector satisfy patients the most? Okay, now somebody asked about waiting lists, and I will talk about that. First of all, just let me look at another piece of research. So this again was interviews of patients, asking them about some of the things that matter when it comes to how satisfied you are with your experience. So getting an appointment to suit you, being able to reach them on the phone, being able to speak to the GP, and how long do you have to wait? And the United Kingdom, which kind of prides itself on having universal access and mostly free at the point of use, a skilled workforce, et cetera, does not have as high satisfaction rates as notice these two countries, Germany and Switzerland. Okay, so when things are free and you've got to take your turn and you've got to queue and you've got to wait, you don't get to see the doctors as quickly, unless of course it's an emergency. That's another matter. So there is some of this disadvantage. But on the other hand, if you look at the previous, if you think about the previous graphs and the outcomes, when you get the care though, it is very, very good care. Okay, and up to now, many people in the United Kingdom have been frustrated, but understood that they're in a wait, that they're waiting to get the care. Not happy with it, but it's been something that's been largely accepted. What's happening now is that care is being a little bit more fragmented. There are many more providers in the secondary care sector than there were, and we'll wait to see what happens with those changes. Okay, I did have, okay, I'm just going to put a question to our Cypriot doctors here, though. The ones from Greece can answer it as well. What is this? Does anybody recognize it? Put your hand up, shout out, type in the answer. No, trick question. Okay, right. It's a 2,500-year-old contract between the state and a doctors organization. Okay, so 2,500 years ago, the then King of Cyprus made a contract with Dr. Onasilos and his family to provide comprehensive care for victims of the wars. I think there were a couple of wars going on at that time. And Cyprus waited 2,500 years to reintroduce a comprehensive healthcare package just about 18 months or so ago. They now have a national health service. It'll be fascinating to see what effect that has. It's a great opportunity because they've taken the steps to unify electronic records across the sectors and to name and to have fixed general practitioners. Slightly differently to now, a general practitioner role varies around the world. I mentioned before comprehensiveness and how important that is. In many countries, family doctors provide comprehensive care, the full range of illnesses that can present to the health service. In some parts of the world and even some parts of Europe and the Middle East, doctors in primary care are restricted. Some, for example, do not do pediatrics. Some do not do women's health. Some do not do mental health. Okay, like I say, you're only you'll get the full benefits of general practice when you have comprehensive care. Now, many different names are used around the world. General practitioner, family doctor. Some in Europe wanted to change it, or some in the UK wanted to change it to consultant family physician. But I think that in Cyprus, you've chosen a very good name, Prosopikos, a personal doctor, because the times have changed. Family units are different to what they were. There are many more single people living on their own, students spread around the world, workers who move around different borders, that actually personal doctor is probably the best name I've seen that's been given for this. Now, very briefly, I know China's not a low-income country. We've mentioned Vietnam here, which is, which I've also mentioned Costa Rica, which is a high middle-income country. But I just wanted to say this because one thing you could turn around to me and say is, okay, Kev, it's all very well. You've given us all these figures from rich countries. It can't work in places where there isn't sufficient resources. Actually, it's the other way around. You know, you get if you remember, primary care is good value for money. It's highly efficient. So spending money on primary care when you haven't got a lot is going to get you the maximum outcomes. So I've just listed a few shining examples here. And if anyone wants the references, you can write for them. I'll happily get them to you. But you know, in Thailand, when they introduced comprehensive primary care, infant mortality went down by a staggering amount, and patients were satisfied. Of course, they were, because they weren't getting care before. Brazil introduced its More Doctors program in areas where doctors were not prepared to go. We mentioned earlier about the inverse care law. I mean, one reason poor areas are under-doctored is because they're not the places doctors want to go and live. So they enabled doctors to go there by building new clinics. And again, a lot more people then had access. China, as I say, huge pockets of rural poverty that were for a country that that calls itself communist, wasn't actually providing communal care until a few years ago. It set up primary care clinics, and the research there shows so far that there is much greater satisfaction with these communal clinics than what they had before, which were largely private clinics. The same experience has been had in Vietnam. Costa Rica did something very similar, a high middle income country, but didn't have much in the way of unified primary care until the middle 90s, introduced a comprehensive program with multidisciplinary team, and again, had improvements in health outcomes as well as satisfaction. I've just put the "and" there just to remind myself. I'm fortunate to have colleagues around the world, some of them here today from Egypt, Kosovo, Armenia. Sunny has joined us from Myanmar. These are all countries facing much greater difficulties than we are here in the UK, but they're making progress or working towards improving primary care. And I just take my hats off to you all, because I think working under such difficult conditions is admirable. It'll be fascinating to see how successful you are. And I've also put down there to remind myself, I know I've talked a lot about family doctors. It's just to say, of course, the primary care health sector also includes nurses, midwives, community psychiatric nurses, child health visitors, etc. And we perhaps need to do a little bit more research on teams as well. Okay, so I've reached the end. If there are any questions, I'll happily take them.
Kev, there is one question, apart from the one on capitation that you said that you're not going to address. There is, what are the possible causes of weak primary care?
Okay, yeah. Well, it'd be nice, I'll answer that. It'd be nice to hear from people who can identify it in their own countries or have identified it anywhere. No, it's perhaps easy. Okay, I'll wait. Put your hand up if you. It's easier to look at it the other way. What is it that makes it strong primary care? If you look at the countries that have done it, it's been driven by two things. First of all, activists in the medical profession. By activists, I mean people who want to see change, combined with support from the Ministry of Health or the political parties. You know, not necessarily one party, but society has made that decision. Either where there has been a strong support from a committed Minister of Health and a committed government, as happened in the UK 60, 70 years ago, as has happened in some of those countries that I've mentioned, such as Kosovo, and when that happened, what, about 10 years or so ago, Vietnam again, you know, once there's the political will and the medical profession is committed to it as well, it seems to work. You do have problems though. So why does it not work in the USA? Well, I think we're all aware of the very strong polarization in that country and the strong fear they've had about having a national health service.
Kev, we have Sonny that has raised his hand and he wants to talk. So.
All right. Oh, sorry, I didn't see that. Yeah, Sonny, come in.
I think I'll talk about my experience, actually. One of the main problems is the political will as well. With that, the trouble is a lot of the health ministers have usually been secondary care specialists who are, so the senior professor usually becomes the Minister of Health. And so a lot of money is spent on big projects such as bigger hospitals, bigger specialist unit, you know, transplantation services, and governments like them as well, because it really is a big showcase, whereas putting money into primary care is never really very glamorous or politically expedient.
Very valid point. Mm-hmm. And I say, please, when you're next in contact with your colleagues there, do pass on my sincere admiration for all you're trying to do in those difficult circumstances.
Well, I have to say that the experience of Cyprus so far is that, I mean, we were glad that we managed to have a primary care system before the coronavirus pandemic hit the world in general, because I think having access to a primary care doctor, people felt that they had the support they needed during this difficult time, and also the access to healthcare that they needed for any emergency, but also for the management of their chronic problems. I think one of the problems that we are facing, though, is the fact that the referral rate to secondary care is still very high. We have about a 72% referral rate to secondary care. And we don't know whether this is because the public is not still used to seeing their family care doctor as the doctor who is going to manage their their health needs, and they're not trusting them as yet, because they were used to having access to secondary care all these years? Or is it because the primary care physicians in Cyprus haven't received the training that they needed to be able to cope with the work of primary care that they needed to do? So that's something that we will. It would be good to debate in the next few years as well.
Thank you. That's a good question from Daniel Unegbu, asking about Cuba with an effective and efficient primary care system. What are they doing that's right? Okay, Cuba is a very interesting country, given the difficult circumstances they've been under with the economic situation there and being isolated. They have very low rates of perinatal death and long life expectancy. So how do we explain that? It is not that easy to do. Partly, I don't know much about the subject, but I think information out of Cuba doesn't come as readily and has not been included in the international studies that I've come across. But their system, they have a very high proportion of healthcare workers to the population. And they also have, let's say, they have primary care practitioners who aren't necessarily trained to the level of a primary care doctor or family doctor as we would recognize here in Europe, but who nevertheless can provide a lot of preventive medicine and management of common conditions. So having many such practitioners who, you haven't invested the huge sums that you've invested in family doctors, having lots of those, as well as some higher trained, more highly trained doctors, might be the secret. That's as much as I know, and I can't say more. Certainly worth looking at. In fact, you've given me an idea. That's going to be my next piece of reading. Thank you. Okay, so.
Kev, there are a couple of more questions.
All right, yeah, I'll just have okay,
there's one from Mohammed.
Do you have any study test WHO role in primary care at low and mid economic countries? That's a good question. There have been lots of WHO reports, and the short answer is yes. And much of the recommendations that come out of it from the WHO invest in primary care. I've certainly got some of those, but I didn't include them in today's lecture because it was much harder to marshal the evidence and use that for discussion. I had not put it on the reading list, but if you're specifically looking for that, Mohammed, do write to me. And then in limited resource settings, does quality primary care have an inverse relationship with universal health coverage? Okay. Might be a little bit scarified so i.e. in order to get universal health care, we might a little bit scarify quality, including, for example, as a solution for high demand of doctors, so we accept lower qualifications. Okay. Another question, if partnership with private insurance in public healthcare is a good approach. Okay, so quite a few questions there. I'll start with the first one. So when you introduce universal healthcare and primary care together, as some countries have done, or you do it in a stepped fashion, we were talking about Costa Rica and Brazil. No, the relationship is not inverse. No, it's actually it's not. No, they go hand in hand together. So if you can have universal coverage, you can choose to resource it well, or you can choose to not resource it well. Yes, clearly, if you resource it well, you will get better results. You've got, like as I was saying before, with comprehensive care and well-trained people. And in fact, though, just bear in mind, you actually save money compared to spending that same amount on secondary care. What about having some less qualified people, less qualified than doctors? This is happening everywhere. Here in the United Kingdom, we are now having nurses who are taught to look after minor illness and who are given prescribing rights, working side by side with doctors. We have what we call physicians associates. These are people who have a degree in life sciences and have then done a shortened, compared to doctors, training in management of minor illness and long-term conditions. And just 2 miles from where I work, there is a clinic that has 5 doctors, 2 personal associates, 2 physician associates, a nurse prescriber, and a clinical pharmacist who assists with looking after people with long-term conditions. So this mix is happening. And it's perfectly sensible to have such a mix in low-income countries and middle-income countries too. And as I said, this is effectively what Cuba has done. Although I'm not sure what the words they use to describe their practitioners are, but this is what Cuba has done. So yes, it can happen there. Mixing private and public health as partners is always yeah, it's done everywhere. I mean, it happens certainly around Europe. The model there is that you use your private care perhaps to top up what the state does. That again can lead to problems of over expenditure if people use that top up to have things that they don't need. What we talk about overdiagnosis and overtreatment. That's a completely different subject. So I'm sorry, I won't go down that line. But there is always a problem when somebody can do something for which they can be paid, and it may not have been medically necessary, but it is done. Okay, so you have to be careful with fee-for-service payments is the main thing that I'm concerned about. Yeah. So,
okay. Thanks, Kev. I think we are 3 minutes to 6 o'clock and should be
right.
closing the session. Thank you all for your questions.
Could I just say a few words before we go?
Yeah, of course.
Very
I
quick.
will need to just have 5 minutes at the end to.
I'll rush this. So the learning points to take away from this: international studies prove it that strong primary care sector gives you better health outcomes, better efficiency for the pounds you spend, better care and health for everyone, including the poorer classes. You know, even in the United States, the richer classes do worse than the richer classes in countries with a poor, with strong strong primary care. Patients on the whole, with some exceptions, have good experiences. You've got to have sufficient resources, comprehensive coverage, skilled workforce, universal coverage, equitable distribution. Now, thank you all very much. If you're interested, there's a handout and a reading list available. If you write to admissions, the people that let you in, they'll send it to you. I tweet occasionally on evidence-based practice and health policy, occasionally on personal matters, but not often, usually about my daughters who are both musicians. But if you want to follow me there and catch up with some of the changes that are happening in evidence-based medicine or health policy, I'll be glad to see you there. Thank you very much. And thank you all for being here.
Thanks, Kev. Now, if you can all stay for 2-3 minutes, I'll just want to kind of share some information with you in regards to our university and okay, so thank you, Kev, for the presentation. And I think we all agree that family medicine, the practice of family medicine is very important. And I think Prof have shown to us the benefits on the nation's health, but also its efficiency for health service. And just to say that the University of Nicosia Medical School aims to, in general, to contribute to the improvement of the population health across the globe, and with the development of 2 undergraduate and 3 postgraduate medical programs now, we have more than 980 students from 63 countries that benefit from our programs. But I think in the area of family medicine, we have been instrumental in the area with the development of the MSc in Family Medicine program, and also a partnership with the Royal College of General Practitioners from the UK to deliver the international membership examination. And we've done that in an aim to expand primary care to all parts of the world. Our MSc in Family Medicine program can lead to the award of the master's degree, but students can also opt to get a postgraduate diploma in family medicine. The program is targeted to doctors who want to have a career in the area of primary care. The delivery of the program is quite flexible. Students can attend the program as full-time students over 18 months, but can take the flexible part-time option of up to 4 years, because we realize that these are doctors who have extensive work commitments, but also family commitments a lot of the time. The mode of delivery is online, and that is to suit the needs of people who work in so many different parts of the world. There are optional on-site clinical skills sessions that we run here at the University of Nicosia, and people are welcome to come and visit the medical school and get some more on-site training, especially if they need to upgrade their clinical skills. The language of instruction for the program is English, and there is also the opportunity that is linked to this program, as it prepares students who meet the eligibility criteria to become international members of the RCGP, to complete the Cyprus MRCGP international exam and thus become international members of the RCGP UK. The MSc in Family Medicine program is a structured continuous professional development program, and what we aim to do during the delivery of the program is to enhance the knowledge, advance the clinical skills towards the management of patients in primary care, develop in our students a more comprehensive, holistic, and evidence-based approach to medical practice, but also learn them to apply principles of patient-centered care, problem-solving skills in the context of general practice. And I think one of you mentioned that having a skilled, apart from Kev, somebody else mentioned when they were when we're in the question and answer session, that training the workforce and having a skilled workforce is one of the important elements for an effective primary care system. Our students, we've run the program since 2014. We have students from 25 different countries, 4 continents. Mainly our students come from Asia, Europe, and Africa, and especially countries where primary care is underdeveloped. And these students are aspiring to be pioneers in their countries in the area of family medicine. Just to show, in the last 3 years, as I said, 41% of our students have come from Asian countries, mainly Lebanon, Iraq, India, and Pakistan. 27% of our students from Europe, obviously Cyprus and Greece, are the 2 countries that we have most of these European students from, but also UK and Malta. And 27% of our students are from Africa. Nigeria, Kenya, and Sudan are the 3 leading countries where we get our students. And our last cohort in 2020, almost 50% of our students come from Commonwealth countries. This is because the international membership of the Royal College of General Practitioners in these countries is considered a very prestigious award. If you're interested in the MSc in Family Medicine program, do email admissions. Also, you can email admissions if you want Kev's handout from today and his reading list. Admissions will also be emailing you to send you a feedback questionnaire, and also they will be emailing you with some information about the MSc in Family Medicine program. And one last thing to say before thanking you for taking part in this discussion tonight is that there's going to be another webinar on this series on family medicine with Sir David Haslam on May 31st at the same time. And the title of that is Not Just a GP. So thank you all for taking part in this session tonight. Thank you for your interest on the topic of family medicine. And thank you, Kev, for such an elegant presentation. Have a good evening. Bye, everybody. Good night. Family medicine is one of the basic cornerstones of healthcare provision. The Master of Science in Family Medicine is a structured continuous development program for doctors who want to have a career in primary care and would like to enhance their knowledge, skills and competencies towards a comprehensive, holistic and evidence-based approach to clinical practice.
This program has broadened my scope and has given depth to my understanding of family medicine and its practice. It has helped me develop a reflective, empathetic, and structured communication pattern with my patients.
We teach the skills of patient-centered care, core clinical knowledge, and critical thinking needed by today's doctors. We offer online innovative learning that combines flexible self-study with webinars, practical activities, and personalized feedback.
The Master in Family Medicine is delivered at flexible time, something that suits my busy professional life. In addition, it gives me the ability to choose my own pathway comfortably and at my own pace.
The Royal College of General Practitioners in the United Kingdom has been working at an international level for over 60 years. Its strategy has been to work collaboratively with host nations to promote family medicine, and especially to support host sites in developing their systems for training and assessing family medicine doctors. The University of Nicosia Medical School is one of only 3 sites across the whole of Europe that offers the MRCGP International qualification. The Cyprus MRCGP International is a component of the MSc in Family Medicine. It is delivered to an internationally high standard and is accredited by the Royal College of General Practitioners.